Good evening. I consider this a great opportunity and to be here in front of all of you. Many congratulations to the Senthil Multi-Speciality Hospital and the organizing team for having conducted a wonderful, focused meeting on hypertension. To me, it looks like one of its kind in Erode happening. Full credit to the whole team, which is led by Dr. Senthil, senior neurologist. I've heard lots about him way back post MD days when I was with Dr. Pranesh. Anybody from Erode will say, go to meet Dr. Senthil. So that kind of this thing, so I'm very happy to see you, sir. And Ananda Kumar, my own student, leading the show here as an organizing secretary. It's a real happiness that you're doing a great job, and I think this is a beginning, and I request you to continue this in this town. So what I'm going to talk about is resistant hypertension. We must have heard about the hypertension, the silent killer, the prevalence, what will happen if you treat them unrecognized, what's the current scenario of patients who are on treatment but not under control, what's the percentage of the patients who are under control, and the several aspects of hypertension you must have heard, including the autoimmune component, the pulmonary component, which you're going to hear from a pulmonologist, the perspective, the endocrine aspect you have already heard. So what I am going to touch upon in the next few minutes is resistant hypertension. So I'm planning to cover it with what is resistant hypertension, how do we approach a patient with resistant hypertension, and how to work up, and what are the management strategies you can adapt in managing a resistant hypertension, and some of the recent advances and non-pharmacological and non-lifestyle changes. That means interventional management strategies for hypertension. I'm just going to touch upon them, though we have the subsequent speaker who is going to talk on interventional therapy for hypertension. Can you change the slides? Yeah. So, I'm going to give you 3 case scenarios. This is a first case. Patient who is a 61-year-old, diabetic for 7 years duration, and known to have hypertension last 8 years. Is 87 kg, and his BMI is 29. His class 1 is fairly asymptomatic. Clinical examination shows a blood pressure of 160/96, heart rate 69. ECG done 12-lead ECG shows evidence of left ventricular hypertrophy. Echo shows a good ejection fraction and echo evidence of left ventricular hypertrophy. Creatinine of 1.4. Other parameters, lab parameters are quite okay. And these are the medications he's on. Metformin 1 gram twice daily, sitagliptin, glimepiride, amlodipine 10 milligram, telmisartan 40 milligram once daily, and hydrochlorothiazide 12.5. Can we call this as resistant hypertension? Because he's on good amount of medications and his blood pressure is 160/96. This is a second case scenario. We've got a 27-year-old female. We just heard about renal artery stenosis. This female, again, no symptoms. Hypertension 6 months duration, occasional headache. Clinical examination, you can see the blood pressure is 180/110. Diminished pedal pulses. Abdominal bruit, as was seen in the previous case. Hemoglobin 11, creatinine is 1.4, potassium is all right. TSH is okay. Again, ECG showing LVH, echo showing LVH, no cardiomegaly. And this patient is on nebivolol 5 milligram, amlodipine 5 milligram, chlorthalidone 6.25, and of course for the headache, some symptomatic treatment. Can we call this as resistant hypertension? Number 2. This is a third scenario, a 51-year-old male, asymptomatic again. Hypertension detected last 3 months. Master health checkup. He comes in and his blood pressure is 150/96. No contributory clinical findings. Creatinine is 1, HbA1c is all right, LDL is 1 or 2, ECG is normal, echo is normal. He's put on telmisartan 20 milligram and cilnidipine 5 milligram. So can we call them as resistant hypertension? So these are the different 3 case scenarios. I will come back to them after this. So what we are going to talk about is what is definition of resistant hypertension. The societies have mentioned office blood pressure of 140/90 despite 3 or more antihypertensive medications at maximally tolerated doses, and one of which is a diuretic. So why I would like to stress this, you just recall, you can recapitulate the case scenarios, you will try to know then what is the definition of resistant hypertension. According to the ESC, resistant hypertension is a situation where the appropriate lifestyle measures are done with, treatment with appropriate maximally tolerated 3 drugs is done, and one of them is a diuretic, the other being the RAS blocker and a calcium blocker. And you are not able to control the blood pressure below 140/90. How do you confirm it? Always do a non-office blood pressure measurement. You can do it by ambulatory blood pressure, which I always do, or home blood pressure measurement, which is, needs a special teaching, education and all that. So one has to have this blood pressure and one has to have ambulatory blood pressure monitoring before you diagnose an individual as having resistant hypertension. American Heart Association is a little more deep into this jadwal, and they say 130/80. You know, there is always a difference between across the Atlantic between the ESC and the AHA. The ACC body always says brings down the blood pressure like how we bring down the level of LDL lower as the decades went by. You know, we were earlier thought of very high level as normal LDL. Now it's coming down and down. So similarly, the aggressive Americans, they bring the blood pressure as 130/80, below which you need to put down as a goal. And if you're not able to do that on 3 drugs, or you're able to do it on 4 drugs, 4 or more drugs. That's what the definition given by them. And this slide depicts you very well the number of medications in the center and the definition. Controlled resistant hypertension, which means you're able to control the pressure, but patient requires 4 more drugs. Refractory hypertension, an extreme phenotype, where patients is on 5 or more drugs and still not able to get a good control. And of course, including a thiazide diuretic. And then is controlled with 3 drugs. It's controlled, it's not a resistant hypertension. Uncontrolled with these, and 130/80, there's a difference between the European society and the American. So what is the prevalence? Prevalence varies in different ways, right from the where you look at. Is it a registry data or is it a clinical scenario? And what is the level of cutoff you take it as? Is it 140/90 or is it 130/80? So it varies from the cutoff points and the area in which you are trying to define it. Overall, it was 30% in earlier trials, but it's come down because of the correct definition which is adhered to. And of course, if you look at the 130/80 as a cutoff, it's going to go up. Different trials have given in nutshell, you would say about 5 to 7% true resistant hypertension. What if you leave the patient with resistant hypertension uncontrolled and untreated? It's a very bad prognostic sign. You can have a very high incidence of cardiovascular outcome in a patient who is left untreated and resistant to treatment. Ambulatory blood pressure studies have shown that there is a 2-fold increase. So we know what is resistant hypertension now. We know when to recognize and how to recognize. And what if we leave them untreated? So what are the factors you can say which contribute to an individual having a chance for a resistant hypertension? Obesity, is one of the factors. High excessive alcohol consumption, high sodium intake, which is quite abundant in our society, advanced hypertension mediated organ damage. This is very important. That's why you need to put the patient with hypertension into a gamut of tests before you are able to identify individual risk level. High blood pressure at the time of diagnosis of hypertension and a very high 10-year cardiovascular risk. If you are depressed, the chance of having uncontrolled hypertension is more. Male 6, black African origin, low income again is associated with the chance of having a resistant hypertension. So these are some of the factors which are more seen and contributing to prevalence of resistant hypertension. So what do we do when once you diagnose a resistant hypertension? First of all, you need to make sure that it is a true resistant hypertension, for which you need to rule out pseudo-resistant hypertension. Look into some of the secondary hypertensions which were alluded to, and of course you need to rule out obstructive sleep apnea, which is one of the important factors responsible for a sustained hypertension. How do we identify a pseudo-resistant hypertension? We need to really look into that. Is why I mentioned always do an ambulatory blood pressure monitoring. Of course there are technical issues with that, but I would encourage everybody to, before you brand an individual having a resistant hypertension, always do an ambulatory blood pressure if possible, or at least home blood pressure with appropriate education of the individual. And then, always once you start a patient on a hypertensive pill, by the end of 1 year, 50% of the people will not continue this. So there is very poor adherence, which is largely related to the number of pill medications, because the hypertension does not go alone. It always goes with his brother, diabetes, and most of them will have other comorbidities like heart failure, coronary disease, and so on. So they'll be on multiple medications. So you need to look at the adherence of the individuals, wherein which the SPCs, single pill combinations, are very, very useful. You can have a 2-drug combination, 3-drug, or even a 4-drug combination at a lower dose. That will definitely help and improve the adherence. So we need to look at the adherence. Patient may say that I have been adherent to this, but you have got some objective evidence to identify by which, by urine test or a blood test level of the metabolites will help you. So always look into that, one of the important factors which are contributing to the uncontrolled hypertension. Then the methodology in which you take the blood pressure, the measurement technique. Somebody old age, will have a calcification of the vessel, so it'll be very spuriously high, so will not be able to come to a conclusion or you are really dealing with the resistant hypertension. So this is very important, and of course you need to rule out the white coat phenomenon, which always occurs whenever an individual visits the office. That is why I mentioned always do an ambulatory blood pressure before you define an individual having a resistant hypertension. Secondary hypertension, I don't want to go much into that, already been alluded to. And in fact, one of the case scenarios I have given was probably a case of secondary hypertension. The causes of pseudo-resistant hypertension, I already mentioned, white coat phenomena, poor method, clinician inertia, resistance on the part of the patient as well as the physician. On the part of the patient, I mentioned the reasons. On the part of the physician, he says, I've given 3 drugs, it should be enough. No, the blood pressure continues to be high. Okay, I've given drugs, whatever required. So there's a high chance percentage of physician inertia in many areas of management of certain specific diseases, including the lipids, blood pressure, and so on. So clinical inertia on the part of the physician is also an important contributing factor, so much so like the patient's adherence. So these are the ways in which you can rule out the secondary hypertension, some of the tests, the clinical suspicion, as was pointed out by the previous speaker, when do you suspect renal artery stenosis. So these things, these tests will definitely help you to identify secondary hypertension so that we can rule out. So the mechanisms, there were 2 important mechanisms for the resistance which is responsible. One is the increased sympathetic nervous system activation and aldosterone excess. These 2 will lead to the sodium retention and that's a volume expansion. These are some of the two mechanisms behind resistant hypertension which can be addressed appropriately so that you bring down the blood pressure. So coming back to the scenario 1, so this gentleman hypertensive for 8 years and is overweight, uncontrolled blood pressure with evidence of hypertension mediated organ damage like LVH. He's on amlodipine, telmisartan and hydrochlorothiazides. He's on 3 drugs. One of them is a thiazide diuretic and he's on fairly good dose. Amlodipine 10 milligram, telmisartan maybe 80 is okay. So, and ambulatory blood pressure is 145/92. This is a true resistant hypertension. So how do we go about? We will touch upon. Scenario 2, a female, young female. What is the positive thing? Diminished pedal pulses. So one has to suspect connective tissue diseases, mainly predominantly arteritis. So again the blood pressure is quite high. So this is again a true resistant hypertension. Of course, she's on 3 drugs, including a thiazide-like diuretic. But then you got a clue for a secondary cause like absent pedal pulses, so which will give you an idea that you are dealing with a secondary hypertension which has to be looked into. This gentleman, again 51, asymptomatic, on a Master Health, found to have high blood pressure, was put on these 2 medications for 3 months but still having a uncontrolled blood pressure. So he's put on a ambulatory blood pressure is 128/76. So this is not true resistant. So ambulatory blood pressure is very, very important. Even though he's on only 2 drugs, but his off his blood pressure is high, but out of his blood pressure is normal. So he is not true resistant hypertension. It's a pseudo-resistant hypertension. So how do we go about managing? You've got non-pharmacological ways, and then you've got the pharmacological and device-based management for resistant hypertension. Non-pharmacological, again, you need to reinforce on the appropriate reduction in sodium intake, weight management, exercise, physical activity, etc. Alcohol, decrease in alcohol consumption. Avoid drugs which, over-the-counter drugs, pills, which can be responsible for aggravating high blood pressure. So this many times patients may not reveal, and you need to dig into this. Ask the patient, probe into the history, then you will probably come out with some of these decongestants which can cause and contribute to this high blood pressure. Sodium intake, again, many of us feel that we don't take much, but actually Indians take quite a lot of sodium, and we need to look into this. Do you have an evidence for this? Yes, we do have an evidence. This TRIUMPH trial has shown that over a period of 4 months, if you have a proper rehabilitation program and then put the patient on appropriate lifestyle measures, you can bring down the blood pressure significant to the tune of 10 millimeters systolic. So it's very, very important then that you need to stress on the non-pharmacological methods in anybody who is diagnosed to have a true resistant hypertension. Pharmacological, when you treat hypertension, you have these class of drugs which are useful in any patients who is put on drug therapy for hypertension. So in a resistant hypertension, as I mentioned, step 1 will be, first of all, make sure you are treating with a true resistant hypertension. Encourage them to have a proper lifestyle modifications. Exclude the secondary causes. And then once the blood pressure is not at target, go to the step 2, which is where you need to look into the drugs that you are going to give. And once you are not able to bring it down, then go to step 3. The step 2 is substitute optimally used diuretic, which I will come a bit later. So in resistant hypertension, as per the ESC 2024, thiazide or thiazide-like diuretics are recommended. That's very important. You need to look at the eGFR. They do work very well even at a very low GFR. In fact, clothalidone works even at a GFR of less than 30. So you need to put them on these drugs. That's very, very important. Make sure that your resistant hypertension is on one of these drugs, and then only you go to the next stage. Loop diuretics, whenever the eGFR is less than 30, change to loop diuretics. Definitely they're going to work well, and You can increase based on the clinical assessment of the volume status of the individual. You can up titrate the loop diuretics. Chlorthalidone, as you mentioned, is one where you can use it even if the GFR is around 30. And once you put the patient on these appropriate optimal dose of thiazide diuretics or thiazide-like, and then you are still not able to control, go to the next one, MRA, mineralocorticoid receptor. I was mentioning you one of the reasons for resistant hypertension is excess aldosterone. So this should work well. We have the time-tested spironolactone, and we have the newer ones like eplerenone, and fibrinon is a non-steroidal MRA, which has got a huge potential, which is coming up, which is jointly used by cardiologists and nephrologists. Amiloride, a time-tested drug, which still holds good in some cases of resistant hypertension, though availability is a problem nowadays. Earlier days, it used to be there in combinations, but now I'm not sure it's freely available. Probably nephrologists will be able to help us on that, or senior physicians can help on. Spironolactone, wonderful drug in many situations, like a patient with a heart failure, with hypertension, even reduced ejection fraction or preserved ejection fraction. It's tested and it's been found to be useful, and as an add-on drug in a patient who is resistant hypertension, you can definitely use them. There is a trial which has shown the use of this drug over and above the benefit you can see compared to the other drugs like a beta blocker, bisoprolol or doxazosine. When you give these patients spironolactone, you bring down the blood pressure. In fact, the superiority is definitely supported by the role on the sodium retention, which I was mentioning you. Eplerenone is equally effective, though it's not as potent in reducing the blood pressure evidence-wise. Theoretically, it should be okay, good. You can use. Amiloride, as I mentioned, it's been shown to be equally effective like spironolactone, but availability is an issue. It can be used from 5 to 20 milligram. Finerenone is definitely a wonderful drug, non-steroidal MRA, which is coming up in a big way, useful in diabetic patients, diabetic kidney disease patients, and heart failure patients. Hypertension, the sub-study of the Fidelity called Fidelity TRH, True Resistant Hypertension Group, has shown that use of finerenone has reduced blood pressure, though you don't expect it to that extent as you see with spironolactone. It does reduce blood pressure, but there is always advantage of finerenone over spironolactone is it doesn't produce much of hyperkalemia compared to spironolactone. So this trial, which is published in Clinical Kidney Journal, has shown that in a group of patients with who were studied in the Fidelity trial on finerenone, those with the true resistant hypertension, when they were followed, the post-hoc analysis has shown that the finerenone reduces the blood pressure to some extent, though not significantly more than what you see with the spironolactone, but hyperkalemia chances are less compared to spironolactone. And spironolactone, of course, when you use, you need to use a binding agent to try to bring down the chance of hyperkalemia, which is quite high actually. You can see this. So next set of drugs are beta blockers and alpha blockers. Though it's considered by the American Society as the fourth line of drug for patients who have got a resistant hypertension to be used, ESC says you can use it individually in a compelling indication situation as a first line of drug. So when you have not put the patient on beta blockers before and you have put the patient on the other drugs like RAS blockers, calcium blockers, thiazide type of diuretics, and the MRAs, still blood pressure is not under control, you can think of putting the patient on beta blockers and or alpha blockers. So compelling indication favors them. A small observational study has shown that a good amount of use is seen with beta blockers and alpha blockers. Vasodilating drugs, alpha blockers are very useful, and centrally acting like clonidine can be add-on drugs, though with good amount of side effects. You can see many times, as was pointed out before, most of the times you see a resistant hypertension, the patient will have a CKD. So you'll be on several drugs. So that's a scenario where you need to use all these drugs together. Hydralazine is one other drug which can be added. Again, these can cause reflex sympathetic activation and some fluid retention, so one has to combine them and take them into account, talk to the patient, and accordingly you have to give. ARNI and SGLT inhibitors have been shown to have a blood pressure reduction in post-hoc analysis of these studies, so can be useful. Of course, there is not the predominant mechanism of their action. One of the mechanisms is blood pressure reduction, hemodynamic advantage, can be used in patients whom you have indications for putting them on these drugs. The pharmacological therapies in a nutshell I already mentioned. Always refer to a hypertension clinic, specialist hypertension clinic, when you are not able to control the blood pressure, which is very, very important. Newer drugs, we have aldosterone synthase inhibitors, lorundrostat and baxdrostat, endothelin receptor antagonists like aprocitentan, RNA interference therapies like inclisiran we use for these LDL. This is Sambasivam, which is useful in blood pressure reduction as a single injection, can maintain the blood pressure reduction over a period of several months. We have some evidence with the baxdrostat and lorundrostat, which is just coming away, recently published in the ACC meetings. It can cause, the downside of these drugs is hyperkalemia. Endothelin receptor, aprocitentan. This is again, the mechanism is same as the whatever we have seen, the endothelin receptor. Endothelin, one of the important vasoconstricting agent. So we have this precision trial which has shown that this molecule is very helpful in bringing down the blood pressure to the tune that the effect is almost comparable to what you achieve with a renal denervation. That's a precision study. That is the new one which I mentioned. Small interfering RNA. Prolonged duration of action is a big advantage, like what we see with the LDL reduction with inclisiran. Just give it once in 6 months. So that will be very useful. Resistant hypertension, this is the flow chart, how you need to manage, which I mentioned already. Once you are not able to control the patient with all the drugs which I mentioned, think about interventional therapy. And once you think about interventional therapy, sit with the patient, involve the patient in the decision making. That's called shared decision making, which is very important. And you can then advise them or suggest them renal denervation. You can do it at an earlier stage as well if you are able to explain to the patient and get into this. The level of recommendation is class 2B. About the renal denervation, one of the device-based therapies, we have this cardiac renal modulator. Apart from renal denervation, baroreceptor stimulation, all these are new device therapies. I'm not going to touch upon, just give an idea that renal denervation is one of the important interventional therapies. Appropriate patient selection and in an experienced center is very, very important. And these are the ways you can do renal denervation: do a radiofrequency or ultrasound or alcohol ablation. All three can be done, but one has to be giving the therapy at the appropriate site, and appropriate and adequate level of denervation is important to get the benefit. Circumferential denervation is very, very important. Distal denervation is very important. In 2014, Simplicity trial came in, and then it actually, in fact, it was kind of a negative trial. So then there was a laid back situation for renal denervation, but now off late it seems to have come back again thanks to the Medtronic company, which is doing a great work on renal denervation. So in global Simplicity trial has really paved way for the reincarnation of renal denervation. Decision making is very, very important. Of course, these are some of the systems which are useful. Where do we do that? There's a recommendation. GFR should be above 40. That's very important. Baroreceptor is all in experimental stage. We have a small level trials which have shown the efficacy of these, wherein carotid body receptor stimulation can bring down the blood pressure in individuals. Only thing is it's invasive, and there are downside because it's an interventional therapy, so it can cause mechanical problems. So you have 2 generations of devices which have been tried. Cardiac neuromodulation, where you need to appropriately modulate the atrioventricular interval so that in a given individual who requires pacemaker and the blood pressure, this can be useful. Bariatric surgery, yes, it can be tried. It's useful and is shown to be in a trial to reduce the blood pressure to a significant amount, and it's a sustained one, so it can be useful in select patients. So the recommendations are, when do you define resistant hypertension? As I mentioned, 140/90 office blood pressure on 3 drugs. One of them should be diuretics. Confirmation by ambulatory blood pressure, that's a class 1 recommendation. And then identify the true resistance by ruling out pseudo resistance. True resistance, it should be reduced to below 140/90, and if well tolerated, bring it down to 130/80. Drugs, as I mentioned, MRAs, the first to try after these 3, and then add on as beta blockers or alpha blockers and centrally acting drugs. Thiazides, appropriate regimen should be used in select patients based on the eGFR. Loop diuretics if GFR is less than 30. Chlorthalidone can still be used. Yeah, this is based on the GFR, how we go about. So in conclusion, resistant hypertension is a significant clinical challenge, first of all in its identification itself. You have to really establish the diagnosis. Use always ambulatory blood pressure, which I recommend. Lifestyle interventions, you try, educate the patient, sit with the patient, spend time, it will definitely be useful. When you're not able to get, stepwise escalation of pharmacotherapies. Address the RAS system, and appropriate use of thiazide diuretics is very, very important. MRS is the first step in escalation, and then followed by newer drugs which are promising, which probably in the coming years will come into play and come into the recommendations. Device therapies, I'm leaving it at this stage for the next speaker to talk about. Thank you.
Thank you, sir. It's always pleasure to listen your talk, and that too making the complex topic into a simple one after a lavish lunch by Senthil sir and SMS team. And what would be your recommendation to follow up the patient? How frequently, and how frequently you have to check for potassium when you start MRAs along with ARBs in resistant hypertension?
Whenever you need to check the potassium, I always individualize. Like in heart failure patients who are you're already on ARNI and MRAs, I do it first 2 weeks. Once you're stabilized with the potassium level, you can do it every 3 months.
Yes, sir. Thank you, sir. The other thing, one more point I want to add is that sir has shown in his slides, one of the slides, licorice, which is used in herbal supplements. Like licorice that is used in herbal supplements, that is one of the agent which is causing the resistant hypertension, that is used in tobaccos where the horns and other, like to give us flavoring agent. That is one of the main reason. Then you have to ask the patient that whether they are using any tobacco products or not. That may be one of the reasons for this resistant hypertension as well.
Sir.
On that meeting of yours, Dr. Rifai had shown that renal denervation reduces the number of drugs.
Yeah, definitely. Definitely.
What is your personal opinion?
Technically,
the cost, I accept the cost is about 9 lakhs, 8 lakhs, 9 lakhs. But you feel it's really helpful in bringing down the number of drugs in these group of patients?
Yeah, it does definitely help in bringing down. But we have to wait for a long, like any 6 months, 1 year, yes. Or next 3-4 years, we do not know whether the patient will go back to the increased number of medications. We need to wait and see.
Yeah, that's what Rifai also was saying the other day when...
First 6 months, yes.
First 6 to 1 year, he has data up to 1 year.
Yeah, that's what.
Beyond that, he does not have data.
Sir, 140/90 is you say it is a resistant hypertension?
you are not able to bring it down below 140/90, yeah.
You can increase the dose, telmisartan, amlodipine. You can
Yeah,
increase the dose, no?
Maximal or maximally tolerated dose of these RAS group of drugs, calcium blockers and a thiazide-like diuretic.
So in that case, you telmisartan 40 and amlodipine 10 milligram only.
It can be increased, yeah, you're right.
It can be
Definitely.
increased, no?
Definitely, if the individual tolerates, you can go up to max dose, yeah.
So in that case, 140/90 with these two drugs, you can increase the dose.
Definitely it can be done, correct, you're right.
Then you cannot say it is a resistant hypertension.
Yeah, we do not, I'm just giving a case scenario, whether the patient's dose was increased by the physician, not increased, depends on the tolerability of the individual. That is why I mentioned what was given in the case scenario. Definitely you can increase, and when your patient is put on these 3 drugs and your ambulatory blood pressure is showing it high, definitely it's a resistant hypertension.
Thank you.
Sir, I have a question. So, basically in the first slide you have shown that optimization of antihypertensive, which includes CCBs and ARBs and which includes of diuretics. Why don't we consider, alpha blocker? Why the guideline says that we can't include an alpha blocker or a beta blocker, rather than there is an importance on ARB and CCB with the mandatory diuretic. So is there any pathophysiology,
No,
why we mandatory these 3 drugs?
one of the 2 things which I mentioned for resistant hypertension is excess mineralocorticoids and the volume expansion. So that is the reason why this was alluded to. But in a given indication, like a patient with a prostate enlargement, definitely they've got a role, no doubt. I'm only generalizing, I'm not talking about individual case scenarios. A patient with hypertension and CAD, beta blocker will be the first ones, no doubt about that.
Yeah, with your permission, I may just comment on that question. Actually, alpha blockers, they have been very much downgraded. They are not even considered as even 4th option or 5th option in any of the guidelines. All this happened after an important study called All-Hat trial, if I'm right. In that All-Hat trial, actually, the cohort which was put on alpha blockers, there was increased incidence of the
Heart failure.
cardiac events and even mortality and
Heart
so on.
failure, heart failure was the main.
Heart failure and so on. But I personally feel like that's only one study, and I think they have used only doxazosine or something like that.
Doxazine, you're right.
And after that, as a class of drug, that was just pushed down. In fact, nephrologists, most of the nephrologists, particularly patients who are on dialysis, almost 75% of our patients, 70% of patients are on alpha blocker as at least a 3rd drug. That really works well. Because CKD is a state of heightened sympathetic activity, and we don't come across any postural drop and so on. So I think, so that prompted me to write a review on appraisal of the utility of alpha blockers in JAPI in one of the articles I have written. I quoted all those things. That's a good question. But you have to individualize the patient, and where it's required, definitely it has got a role. Definitely it addresses the sympathetic activity so well, alpha blockers.
Same point is there with beta blockers also. They have been downgraded predominantly because of a couple of studies, like you mentioned a lot. There's one study called this life study, and another called this ASCOT. Both of them used a comparator as a beta blocker, and they found the increased incidence of stroke, and so the beta blockers were downgraded. It all depends on what beta blocker was used. As you mentioned, the alpha blocker which is used for doxazosine. We do not know, prazosine might have a different thing. So it is better that we don't take it as a whole. It doesn't mean that all the patients you have to go in that order. Individualize, choose accordingly.
So one more question from my side, sir. Sir, as it defined, resistant hypertension is the inclusion of ARB and CCB and then diuretics. So what we normally face, not in all patients, but the risk of hypokalemia, sir. So I have one or 2 patients I faced personally. I started them on telmisartan maximum 80, and then amlodipine maximum 10, and then chlorthalidone 12.5. I faced significant hypokalemia. So the patient potassium went up to 2.7 or 2.8. So I want to stop it. So for that replacing, I added a beta blocker, and then the potassium it normalized. So whether we can restart the chlorthalidone again, or we shouldn't restart, or we should add on a MRA and then bring the potassium to some extent, and then we can restart the CCB again, diuretic, thiazide-like diuretic again, or once potassium is low, whether we should not restart it again at all.
Your point is well taken. The downside of this thiazide diuretics is this dyselectrolytemia, which we have seen time and again. So you need to definitely monitor the level of electrolytes. We have seen patients with indapamide having a significant hyponatremia to the extent that you need to stop them, and you need not stop patient. The physician themselves, they stop. The physician has developed this, and the physician himself says, no more diuretic for me. So this has happened with chlorthalidone and indapamide are the two notorious drugs which can cause this dyselectrolytemia. Once you have this, definitely you already put the patient on a RAS blocker, that is telmisartan. One thing you can counter is increase the dose, number one. Number two, add an MRA. And once your pressure is under control, it's not necessary that you need to put them back on these thiazide diuretics.
No, even on putting on MRA, the BP is not under control.
That's what.
So I want to add on a
go to the other
alpha
drug.
blocker.
Alpha blocker or beta blocker, yeah.
So we need not restart it again.
No, once the patient has side effect, how can you start?
Okay.
Of course, you need to look at the secondary cause for hypertension when you have hypokalemia.
Okay, sir. Okay. Thank you.
Yeah, a patient who's, despite being on ARB, somebody develops potassium of, somebody has potassium is 2.4. I would strongly think in terms of monogenic hypertension after ruling out renal artery stenosis. It can be a true medullary excess, or apparent medullary excess, or pseudo-medullary excess. So actually in such a situation you are supposed to stop all these drugs and go for general drugs which don't interfere with renin plus PRA activity. Then you have to ask for plasma renin activity and aldosterone level. That will solve the issue. In case you are not able to do that, and you are not able to meddle with any of these drugs, stop these drugs, practically what I do is that, as Sir said, like we start on spironolactone. And after starting spironolactone, you have to wait patiently at least for 7 to 10 days for its impact to be shown. Because it acts at the medullary receptor level, which is the intracytoplasmic receptor, acts at the level of transcription of mRNA, which encodes for all the channels. So you can't expect any impact immediately. So wait patiently for 7 to 10 days. In spite of spironolactone, if the potassium is not picking up and you have ruled out renal artery stenosis, your diagnosis is Liddell syndrome, you have to put, the BP will get controlled with only one drug, that is triamterene or amilorate. Okay, that's how we approach. And once you miss this at that point of time, what will happen is uncontrolled hypertension will lead on to kidney failure, and the potassium will get normalized. Nobody will think of this on that other side. I mean, it will never come to surface again. Because of the hypokalemia, because of renal failure, it will just get normalized, but the patient will not be doing well, and it will go on and on and on until the kidney damage happens. So this monogenic hypertension is pretty prevalent, but we don't see that, we don't detect it.
Thank you, sir.
Thank you so much, sir. Thank you, sir, Dr. Sambasivam, sir, your true authority in interventional cardiology, for that highly informative session. It's always a privilege to hear your pearls of wisdom distilled from decades of rich clinical experience. Your insights continue to inspire and educate all of us. May I now request the chairpersons to hand over the memento to our honorable speaker, sir. And I request Dr. C. Senthil, sir, to hand over the mementos to our esteemed chairpersons. Dr. Anand Kumar, sir, can you please get onto the stage, sir? Dr. Gauri Shankar, sir, urologist in SMS Hospital, kindly get onto the dais, sir. So next, we have a memorable moment for the team SMS. It gives us immense pleasure to present the first copy release of our book, Stories in Scrubs, a heartfelt collection of rare and remarkable clinical cases managed at Senthil Multi-Speciality Hospital. Each story stands as a testament to the power of teamwork, clinical acumen, and the multidisciplinary approach that defines our institution. These cases not only challenged us but also taught us invaluable lessons in patient care, and we are proud to share these experiences that reflect the spirit, dedication, and resilience of our medical team. May I request Dr. Sambasivam sir to release this book, and I request sir, Dr. N. Gopalakrishnan sir, to please accept the first copy of the book. In the presence of Dr. C. Senthil sir and Dr. Gauri Shankar sir and the other cardiologists.